Thank you, Sherry. That was very kind, I think. Polycystic ovarian syndrome is a condition that's baffling to many healthcare professionals, and I'm probably one of them. It's probably because its etiology is unclear, its diagnostic criteria are very fluffy, and it's got a myriad of treatment options that you just can't decide what's going to work for your patient. Today I'm going to show you what I understand about polycystic ovarian syndrome. And hopefully some of this you can take back to your office in diagnosing and treating patients with the condition. This is a patient with polycystic ovarian syndrome. This is a laparoscopic view. So you're looking down into the pelvis. You can see the uterus. The bladder's up here. This is the sigmoid colon down here. This is your left ovary. That's the right ovary. There's the suspensory ligaments. Here you see these two large ovaries, and trust me, they're about 2 to 3 times normal size. The capsules are very smooth. They look almost leather-like, and there's no evidence of any follicular development on the surface of the ovary at all. You contrast to this picture. This is a much closer view of a normal ovary, and we've had to get closer just so we can see the surface contours. So uterus is way up here. This is the left uterosacral ligament. This is the left fallopian tube. Here's your ovary. You can see there's lots of surface contour. There's even a collapsed follicle. That's about 1/3 of the size of the ovary that you saw previously. Here's another patient, polycystic ovarian syndrome. She has uterus over here. Here's this ovary again, quite enlarged. And you can see it looks almost leather-like. There's absolutely no evidence of any follicular development of any kind. This is a cross-section of a woman with an ovary taken from a woman with polycystic ovarian syndrome. And going from the inside out, you see this very thickened capsule. And you see all these incompletely developed follicles throughout the ovary. And if you look at these under the microscope, what you're going to see is a relative decrease in granulosa cells, which produce estrogen, and an increase in pica cells, which produce androgen, and give that androgen, excess androgen environment to the ovary, which interferes with ovulation. What I'm going to talk about today is the prevalence and etiology of polycystic ovarian syndrome, how it's going to present to patients in your office, how you can do the diagnosis and treatment, and what sort of investigations you can do to confirm the diagnosis. Polycystic ovarian syndrome is the most common endocrinopathy in women. This is really quite remarkable, and we're not. I bet you. My estimate is that we probably only pick up about 1 out of 4 women that have the condition. It seems to be that the prevalence is similar across different populations and across different ethnic backgrounds. And it's characterized by chronic anovulation and hyperandrogenism. Women with PCOS, hirsutism, and infertility, and you really should classify them as a high-risk pregnancy. Not only do they have a higher incidence of gestational diabetes, something that we all know about, but they're also more likely to have problems with premature labor and preeclampsia. Obesity is more common, mood disorders are more common, and then later life, they're more likely to develop endometrial cancer by a factor of 3, 4 to 6-fold increase in the incidence of type 2 diabetes, and a 5 to 11-fold increase in the incidence of metabolic syndrome. Now I'm going to take a line from one of the previous speakers and say that genes load the gun when the environment pulls the trigger. These patients, it looks like polycystic ovarian syndrome is a genetic disease with similar inheritance to type 2 diabetes, ischemic heart disease, metabolic syndrome. So individuals start out with a certain genetic load, and that's influenced by their environment and mainly by obesity, diet, and insulin resistance. And that will result in varying degrees of syndrome expression. It's felt that this genetic predisposition probably begins in utero, reprogramming the fetus for insulin resistance and androgen production. The kinds of patients that you're going to see this in your office are patients that come in with infertility. They're much more likely to have a diagnosis. Patients later in life with obesity and insulin resistance, premature adult and adolescence. If you have a first-degree relative with polycystic ovarian syndrome, if your sister or your mother has polycystic ovarian syndrome, then you have a 20 to 40% chance of developing it yourself. Women on seizure medication are more likely to develop polycystic ovarian syndrome, and valproate is of particular interest. It seems to cause epithelial hyperplasia, or proliferation in the ovary, resulting in increased androgen production. This is how, just another representation of how a patient will present to your office. The two most common presentations are infertility and hirsutism, and then amenorrhoea, obesity, and lastly, dysfunctional uterine. There's all sorts of diagnostic criteria, and I alluded to that earlier. That's one of the problems with making the diagnosis, is there's different criteria set out. And I'm going to use what was put out by the Androgen Excess Society, but you didn't know that there was an androgen. If you want membership, you can talk to me afterwards. And what they did is they set out 3 criteria, and pretty well all that what they set out by the other groups are very similar. But they set out 3 criteria. You need to have ovarian dysfunction, you need to have hyperandrogenism, and you need to exclude other disorders. Ovarian dysfunction, you can get just by taking a history. If there's infrequent irregular periods, that would meet the criteria. They also set out an ultrasound part of the diagnosis, where if you had ultrasound evidence of polycystic ovaries, then you could use that. And I don't use that myself, I'll tell you why a little bit later. You need to have evidence of hyperandrogenism, and that can either be clinical or biochemical. So if your patient has hirsutism, chronic or male pattern baldness, or acne, or you can have biochemical evidence. An elevated total testosterone or elevated free testosterone. And then you need to exclude other disorders. This is an ultrasound, vaginal ultrasound picture of a woman with polycystic ovaries. Polycystic ovaries can be found on ultrasound in 20% of normal women. That's one of the reasons why I don't use that as a diagnostic tool. The other reason is it's very difficult to get a technologist or a radiologist that's interested in reporting it. In fact, I don't recall any time in the last 20 years that it's been reported. So I don't use that as part of my investigation for PCOS. So here's a patient that presents to your office. She's 25. She's had 9 months of infertility, and her cycles are 2 to 3 months apart. What are we interested in her history? Obviously, we want to take a menstrual history. Sounds pretty simple, but it can be difficult, especially if your patient had menarche at age 15, went on the birth control pill at age 16, and just stopped it a year ago, and now has, or 9 months ago, and now has had infrequent periods. Is there any evidence of clinical hyperandrogenism? And what are the onset of symptoms? If you have relatively acute onset symptoms like hirsutism over a 3 to 4 month period, you're going to be thinking more of androgen-secreting tumors or things like Cushing syndrome, something that comes on suddenly. Is there a history of infertility? And obviously, in this patient, there is. Is there a family history of polycystic ovarian syndrome? And we talked about that. But it's also important, even in the male members of in the family history, if there's incidence of, if there's a preponderance of type 2 diabetes or cardiovascular disease, that's going to make the patient more at risk for having PCOS. On your physical examination, you're interested in BMI and waist circumference. Obviously, you want to check for hypertension. Hirsutism, acne, striae, acanthosis nigricans, vitiligo, and easy bruisability. This is an example of a woman with PCO with acanthosis, a good marker for insulin resistance. Differential diagnosis of PCO, that's the third part of making the diagnosis. It's important that you need to rule these things out. Congenital adrenal hyperplasia, adult onset, Cushing syndrome, obesity, androgen-secreting tumors of the ovary and of the adrenal gland, hyperprolactinoma, and acromegaly. Now, being that I've been in practice for 30 years, I think I'm allowed a few mistakes. So, these are my diagnostic mistakes. These are patients that came into my office, and I can tell you a story about each one of these cases with abnormal hair growth and irregular periods. And the lesson is, all that comes into your office with abnormal hair growth and irregular periods is not PCO. And I sent them out of the office with a diagnosis of polycystic ovarian syndrome and wanting to confirm it with diagnostic investigations. And what saved me was that I sent them out with a lab. And I did the appropriate investigations and found out that my working diagnosis was incorrect. So your laboratory investigations are pretty straightforward. If there's any suspicion of pregnancy, you want to check an HCG, you want to check your thyroid, you want to check your prolactin. A total and free testosterone, that will rule out androgen-secreting tumors of the ovary and also give you a clue as to whether there's any biochemical evidence of hyperandrogenism. If you're suspicious of adult onset congenital adrenal hyperplasia, it's almost always related to a 21-hydroxylase deficiency, and you can do a 17-hydroxyprogesterone, 17-OHP. If you're suspicious of an androgen-secreting tumor, the symptoms can come on quickly. If you're suspicious of an androgen-secreting tumor in the adrenal, you can take it and you can check a DHEAS. That's only produced by the adrenal. FSH, LH, and estradiol will rule out premature menopause, will rule out hypothalamic amenorrhea, and while you're at it, check the fasting glucose, and I don't do a ultrasound to make the diagnosis. These are all the different treatment options for polycystic ovarian syndrome, and they're all very efficacious in certain situations in women with PCO. Obesity surgery is fairly investigational now, but there is some small studies suggesting that it's not a bad treatment in extreme situations of obesity. And I'm not going to go through that whole list, but we'll talk about some of them when we talk about treatment. So in deciding which of those, that big list of treatments that you can offer your patient, you need to know what they've come to you for. This is a condition that they're going to have for their lifetime, and what they require in treatment is going to be different at different times in their life. At the same time, now that you've made the diagnosis of polycystic ovarian syndrome, you can counsel them about what potential future problems that they may have, like type 2 diabetes, metabolic syndrome. And remember that PCO is an additional risk factor. It's additional to obesity if they happen to have it. It's additional to their family history. This is a diagram I stole from an article in Medscape, and I really liked it because it showed where when we see patients at a younger age, they're going to present more with reproductive problems. They're going to have more problems with contraception, with infertility, with hirsutism, and these problems become more metabolic problems as they age. The first metabolic problem that they'll often develop is gestational diabetes when they get pregnant. Another marker for subsequent development for type 2 diabetes. And so reproductive disorders begin to thin out, and metabolic disease becomes more of a problem. So treatment for infertility, as our patient that just came in, first of all, the birth control pill. It's not a treatment for infertility, but it's something you can talk about in pre-pregnancy counseling in women with PCO. Generally, we advise women, when they come off the birth control pill, wait till they have regular cycles and then try and get pregnant. Well, somebody with PCO, that's just not going to work. And in fact, probably the best chance of getting pregnant is immediately when they come off. Because what you've done with the birth control pill is you've lowered their serum energies, and you've created the environment where they've got a really good chance of having a few good ovulations before they get back into their old vicious anovulatory cycle. So my advice to patients on birth control pill, stop on Sunday and start trying to get pregnant on Monday. Weight loss is very important. There's all sorts of data out there that shows in a woman with PCO who is obese, and that's about 60 to 80% of them, as the weight comes down, serum androgens come down, frequency of ovulation goes up. Even if they don't get pregnant, their responsiveness to ovulation induction agents will be that much better. And infertility clinics are great places for weight loss. Ovulation induction, primary therapy is that of clomiphene citrate. It's about 80% effective. Not all these patients will necessarily get pregnant. And those who do not get pregnant, the second-line therapy are those listed: letrozole, exogenous gonadotropins, which can be quite costly. And lastly is laparoscopic ovarian electrocautery. All of these second-line therapies seem to have equal efficacy. And if finances are a problem for your patient, then one thing that you can consider referring them for is consideration of laparoscopic ovarian electrocautery, because it's much less expensive. It's probably something that's really underutilized. This is that patient that we had earlier on. So uterus here, there's the ovary. And maybe some of the older members, I ran this by the residents at Lone General Hospital. They didn't know anything about Stein and Leventhal. But back in 1925, some of you probably remember, Stein and Leventhal were two gynecologists in Chicago, and they took very obese, hirsute women with polycystic ovarian syndrome. They did laparotomy, and they took big wedges out of each ovary. And these patients who had never ovulated spontaneously in their life began to have regular ovulations and became pregnant. And it was thought at that time that somehow they were interfering with male hormone production. They didn't really understand it. They didn't have the assays or anything like that. That operation kind of fell out of the way when good medical treatment for ovulation induction came along. But back about 15 to 20 years ago, for patients that didn't respond to medical treatment, ovarian electrocautery came along. And what you do is you do a laparoscopy, and you just burn 5 to 15 holes in each ovary. And you get the same kind of response that you do with an actual wedge resection. And these patients will usually start ovulating quite regularly shortly after the surgery. I have a patient who couldn't afford exogenous gonadotropin, was a clone non-responder. We did ovarian electrocautery, she became pregnant. She came back to see me at age 2 years of age, when her daughter was 2 years of age. Again, on anovulatory, and asked if we could do it again. And we did, and it worked. When we went to look at the ovaries again, there are all these little black freckles from the previous attempt at ovarian electrocautery. You may wonder why I haven't mentioned metformin. About 12 to 15 years ago, there's a lot of excitement about metformin. It was thought that the etiology of PCO was related to insulin resistance, and using metformin was going to reverse a lot of the problems that we see with PCO. And so we were putting everybody on metformin, and unfortunately it's been very disappointing. It probably has a bit of a role as a second-line treatment of birth control pill like progestins and treating oligomenorrhoea. There's no benefit in hirsutism. There's minimal to no benefit in infertility, although some clinics will still use it a fair bit. If you added clomiphene citrate and clomid-resistant patients, it may be a benefit, but it seems to increase ovulation, but not pregnancy rates. It was also tried in reproductive proportion. There was not of any benefit. I still see a lot of patients that have been placed on clomid for weight loss. Metformin for weight loss. The data is kind of shaky for that, and to be honest, I think that patients that lose weight on metformin don't have insulin resistance or losing weight because they're sick on the medication. Treatment of hirsutism. Here's a patient with dark pigmented hair up the linea alba. Another patient with pigmented hair on her chin. This can be a hard thing to find in physical examination because electrolysis and lasers getting so good, it can be very difficult to find, and often you have to go with the patient's history. Lifestyle changes, weight loss works for hirsutism as well. Again, you can see androgen levels fall as the weight comes down. The mainstay of treatment for hirsutism in patients with in these patients is birth control pill and spironolactone. Both of these seem to be equally efficacious. I don't have personal experience with finasteride. It is very important that patients on either spironolactone or finasteride have another form of contraception. Again, metformin doesn't work, and electrolysis and laser is quite effective, but it is expensive. Treatment of oligomenorrhea and dysfunctional bleeding. Weight loss, again, is effective if your patient is obese. You may remember about 5 years ago or 6 years ago, there was a lot of interest because there are some studies on using the birth control pill in normal women that suggested that it increased insulin resistance. And there were some comments that the last thing we want to do is to give the birth control pill to women with PCO who already may have insulin resistance or certainly a tendency. But in fact, it's probable that it has a reverse effect in women with PCO. The reason is that a birth control pill will decrease androgen production and androgen levels in women with PCO. And we know that androgen increases abdominal adiposity. Abdominal adiposity increases insulin resistance. So as we get as we get androgen levels down, we can decrease abdominal fat, and by decreasing abdominal fat, we can decrease insulin resistance. So in women with PCO, it seems to have the opposite effect. Other options, if you're just trying to make sure that your patient has at least 4 periods per year, you can use a progestin of your choice. You can use Micronor, hydroxyprogesterone acetate, or prometrium. Mirena IUCD is also an excellent choice for prevention of endometrial hyperplasia. It's also an excellent treatment for treatment of endometrial hyperplasia. And there might be a role for metformin in increasing the frequency of periods. So, for disease prevention, if you made your diagnosis in these patients, I think these patients deserve earlier screening for things like lipid abnormalities and for glucose abnormalities. And of course, it's important to counsel for lifestyle modification. In summary then, PCOS is a common disorder, and I would encourage you to try and find these patients in your practice and make the diagnosis. It's important to treat the current problems, and it's important to counsel and treat for future problems. Sure, you said I had to make up sometimes.
I'm disappointed that the gynecologists are disappointed in metformin because I've used quite a bit of it for a while, but I guess I haven't done that. Questions?
Yeah, hi. Great lecture, thanks. I have a 35-year-old, 100-pound, very skinny woman who has one ovary listed as PCOS, and the other one's apparently normal. Elevated prolactin at 31. All of her other labs are normal. She's been trying to get pregnant for about a year. She's undergone acupuncture 2 to 3 times a week, and it's actually normalized her cycles, which is huge because they were only 3 to 6 months for menses. And I'm just wondering when would be a useful time to initiate like a Clomid trial.
Sorry, you said she was 100 pounds?
Yeah, she's about 102. She's very thin, very thin.
Yes, first of all, I wouldn't necessarily assume that would be polycystic ovarian syndrome.
Even though 2 different endocrinologists have said yes, for sure it is. Yeah. Just in case I was wrong, I sent her off.
Well, just to read, she sounds like she's underweight, and the first thing I would think of would be a hypothalamic amenorrhoea or hypothalamic dysfunction,
Yeah.
So, and you have to sort of look at her hormone profiles in context, but
They're beautiful. She looks like a racehorse, and I've tried to get her to gain weight, and it's very difficult. Yeah, and her mom has PCOS as well, so that's interesting.
Well, and certainly you could consider trying her on hormone considerate improving the quality of her ovulation. You could look at her serum progesterones in the second half of the cycle, see how they look. And I would, make sure you complete all her investigations, make sure there isn't a tool factor or anything else.
It's all been done.
Well, if she's having normal, regular ovulatory cycles, then you could almost classify her as an idiopathic infertility. I mean, you don't know why she's not getting pregnant. If she's got ovulatory cycles, it's not from ovulatory dysfunction.
Yeah.
So you can try clomiphene citrate empirically, which has been shown to help in patients with idiopathic infertility, or refer on to more intensive treatment like IVF or stimulation.
Yeah. Okay. Thanks.
Thank you, Dr. Benoit. Your talk was excellent. I was wondering about future screening for older patients with PCOS, say in their mid to late 40s, kind of giving up on getting pregnant and so on. Do they need to have sort of regular endometrial biopsies as a screening for uterine cancer?
If they are anovulatory, so if they're going several months without a period, then certainly, for sure. If they're having 28 to 35 day cycle, then almost all the time that's an ovulatory cycle, and it's probably unnecessary.
Thank you so much for this talk. Actually, I had a 31-year-old lady case of PCO. She was on spironolactone for hirsutism, and she got pregnant on spironolactone. She stopped the spironolactone on gestational age of about 4 to 5 weeks. 4 to 5 weeks. And that was really challenging because for some religious problem, they didn't want to do abortion, but they just wanted to make sure the baby is safe. We discussed this in medical genetics at BCCFP hospital, and with some obstetricians there was some different thought about that, but I was wondering what's your idea, because the final conclusion on that was because probably because the sex organogenesis is something on weeks 10 to 12, and she had stopped the medication on week 4 to 5 with attention to the fact that half-life was 5 to 8 hours. They thought there wouldn't be any problem with the baby, even if it's a male baby. So I was wondering if you have any comment on that.
I would support that. I mean, that's very early gestation, so I think the chance of it being a problem. I mean, you have to cover yourself by saying you can't give the patient guarantees. I think that would be a safe choice.
Thanks.
Well, thank you, Dr. Benoit, and we'll see you back in Kelowna.